Right, good afternoon. Thank you very much for joining us on another rainy Wednesday afternoon in the UK. This week, our third speaker, we have Mr. Neil Jain. So what I'd like to do is just introduce him first of all. So we go over to Neil. You can say hello.
Hi Giles, hi everybody. Thanks for logging on.
And what we'll do is I'd like to tell you a little bit of information about Mr. Jain first of all. He's a specialist in the treatment of all sports injuries, including the surgical treatment of injuries to the shoulder, such as dislocation and rotator cuff repair, but unusually he's also a knee specialist as well. He's actively involved in teaching, having lectured at the University of Manchester, Liverpool and Lancaster about the orthopaedic and sports injuries, and he's well regarded for his strong research background, have published many peer-reviewed journals as well as medical textbooks. He's an active member of ESCA and the present treasurer of the BOSTA, which is the British Orthopaedic Sports Trauma and Arthroscopy Association. And he completed his sports injuries and reconstructive surgery arthroscopy fellowship at the world-renowned University of British Columbia in Vancouver, Canada. And he's worked with a number of sports clubs and associations at both amateur and professional level. More recently, he's collaborated with the English Football Association to help decrease their injury rates in the England national football team. So before we start, as always, we're just going to go through a few sort of bits of information about housekeeping and how to contact us and how to chat to us. So effectively, the main way to communicate with us is through the Q&A function. So you can put questions in there, and then I will pose those to Mr. Jain. If we can't answer them at the time, we will come back to them. You can also use the chat function as well. The sessions will be recorded, and you can actually find all the previous recordings on the Össur Academy YouTube channel, which my colleague Stuart's going to place in the chat function now, so you can see that. There will be an e-certificate coming up out to you in the next few days, and a follow-up questionnaire. We do realise last week that there was a small issue, and you actually received one or two more emails than perhaps we would have wanted. So we have fixed that. So apologies if that was an issue. So all that really remains for me to do is to pass over to Neil, and he can then start his presentation. As I mentioned, I'll be manning the chat function and the Q&A. So I'll pass over to you, Mr. Jain.
Brilliant. Thanks, Giles. As always, very kind and very humbled by how you describe me. I'm sure I'm not that good. Anyway, so let's crack on and share the screen. Thanks, first of all, everyone, for coming. My name's Neil Jain, as Giles says, and we're just going to take a little bit of lighter relief in terms of what's going on in life at the moment, and look at rotator cuff tears and how they might bring a different challenge during and after lockdown. Sorry. There we go. So first off, thanks everyone for coming. Thanks for logging on. Big thanks to Össur for running these things, because obviously times like this, CPD takes a back seat, and companies like yourself promoting education for really a topic that you don't have much of an interest in yourselves, I think says a lot about you as a company. So thanks for that. First and foremost, hope everyone is safe during these tough times, and that your families are as well. It is a difficult time, so let's try and take the next hour or so. We'll make it as interactive as we can in this forum. I think there's 350, 400 people logged on, so that's just a sign in itself that it has to be some form of pandemic with nothing better to do at this point than listen to me. But as Giles says, there's questions, and he can interject with those questions at any time, and we can try and use the medium to make it interactive if we can. First way of doing that, we're going to throw up a few polls to the audience at various times, and this would be the first poll, just to get a rough idea for us to know who's attending, but also to check the polls work. If people wouldn't mind just jotting in what your role within the MDT is, that'd be great.
So we have about 70% have answered so far. We'll just leave it up for a few more seconds. Okay, brilliant. So we're just over 80%. So I'll just end that there and then share those results. So we have a few consultants, a few trainee surgeons, a few doctors, nearly 80% physiotherapists, 2 OTs, 36 orthotists, 2 nurses, and 26 others.
Brilliant. Well, welcome one and all. I'll try and then gear it up, and hopefully there'll be bits in it that everyone can take something for it. But yeah, fingers crossed that most of the physios who are here, you can get something from this spiel as well. All right, brilliant. So what we're going to do is talk a little bit about, obviously mention COVID, some observations that I've had during this lockdown period in my practice already. And then we'll have a brief overview again of the anatomy, and then throw in some top tips about how to take some virtual history and examination techniques. And then summarize at the end a bit of a follow on what's going to happen after lockdown gets released and how best we can manage patients. I really think we'd probably have to have our head in the sand completely to not know that there's a worldwide pandemic going ahead. The COVID-19 has changed all our lives in the last couple of months, some longer in terms of where we live. And we've been on lockdown here in the United Kingdom for getting on for towards 4 or 5 weeks now. And that's led to some challenges practically with how we're able to deliver care, and particularly in our specialty, orthopaedic surgery, particularly with something like rotator cuff tear, because it's not, generally speaking, considered an absolutely urgent pathology, and perhaps rightly so. So within the NHS practice where I work, we're doing no elective surgery at the moment. And rotator cuff tears would traditionally be under the elective surgical banner. They are gradually going to be reintroduced. And I think this week at Rochdale Infirmary within Greater Manchester, we have started to do some cancer surgery, time-dependent, urgent, clinically important surgery. And that certainly will take more of a precedent than something like a rotator cuff tear, because traditionally the nature of a cuff tear has been non-urgent to get to surgery. Similarly, we would tend to see these patients in our elective clinic, and they've all been eliminated at the present time. Even in fracture clinic, we're limiting the number of face-to-face reviews, so there's a lot of telephone and video consultation that's happening instead. Conversely though, there's a lot of people who are spending a lot more time at home, and they're looking for various things to do, more ways of occupying their time. That's led to an increase in DIY, people making things at home themselves, an increase in gardening, and an increase in cycling. Every day I do drive to work, I seem to pass 6, 8 cyclists on the road. So there's certainly a lot of people still getting out and about and doing some activity that way. Now, anecdotally, what I've seen so far when I've been doing the fracture clinics is that we've been seeing an increase in terms of the open wounds, an increase in patients with deformity, and also dislocation. So these patients really can't stay at home. They've still been coming in. However, from all the consultations I've been having via the telephone, there's definitely a proportion of people who are fearful of coming to hospital. When we phone them, part of the procedure is to try and determine, are the benefits of coming for a face-to-face consultation outweighing the risks of coming to hospital for that individual? And what I find a large proportion of the time is that patients, before I've even said anything, I say, oh, I don't really want to come. Is it all right if I don't come? And the feeling is that there is a fear from coming to hospital. And I think that's been highlighted as well at government level recently, that in things more severe than cuff repair or cuff tear, heart attacks, strokes, people are still suffering these and are sadly not presenting to hospital. So realistically, it's no different for many other things. So a little theory that's kind of prompted the topic, the nature of this talk, is to think about cooking, baking. It's become quite popular in the lockdown in the UK. And if I was to throw out the following ingredients, somebody over the age of 50 doing more DIY and sustaining more risk of injury doing DIY, doing more gardening, lifting, pulling, moving pots around the garden, more risk of injury there. They're more likely perhaps to suffer an injury that's not significant enough to present them to the A&E emergency department, especially not at the moment during the pandemic. Well, I put to you that that mixture, that set of ingredients can be put together and cooked and create the potential for a rotator cuff tear. So conceptually, my thoughts are that we could be actually seeing a number of the population suffering cuff tears through this time, but without actually presenting to the emergency department in the traditional way. So that leads us to another poll, and just to get people's opinion, do you think this is a legitimate thought process, a logistic theory? A simple yes or no, Giles, if you wouldn't mind. Oh, thanks.
So do you think there'll be a surge in cuff tears in lockdown, yes or no? So a couple of people have also mentioned that sometimes the polls don't pop up. That's actually related to the fact if you join from a browser, sometimes you don't have all the functionality. So if you're able to join from the Zoom app, it does help with that. So we're up to about 80%. So I'll end that there and then share those results. So we have 79% saying yes and 21% saying no.
Well, thank goodness for that, because if the majority had been no, or it had been like 100% no, I'd have probably had to stop the talk now. So yeah, that's good. So we've sold the idea, at least to you, that we think this could be a problem going forward. So let's get back onto track on what we were thinking. So quick overview of the anatomy of the rotator cuff. We've got a view from posteriorly and a view from anteriorly now. And a couple of things to think about: what muscles are in front of the scapula, what muscles are behind the scapula, and what muscle is above the scapular spine. And when we think like that, we can determine effectively the functions and then how to test for each of the rotator cuff muscles in turn. And while most of the audience will probably already know this, we'll go on and try and give some top tips about how we might do that in the lockdown situation via telephone and virtual consultations. So just to review the function related to the anatomy of each muscle related to the scapula, the supraspinatus lies above the spine of the scapula. Therefore, it would lift the arm above the level of the spine of the scapula. The infraspinatus, anterior minor, is below and behind, and therefore, upon contraction, would cause this posterior rotational movement of the arm against the scapula, i.e. external rotation. Similarly, subscapularis lies below and in front of the scapula, causing the opposite movement, the internal rotation, or medial rotation, as I know some people call it as well. So that's just briefly touching on the functions and the anatomy of the rotator cuff. Now, at the moment, most of us could still be doing telephone consultations, some of us doing video consultations. And these patients may present either by the telephone, by video, or as we've touched on, they might just stay at home and delay their presentation until we're post-lockdown. If we are conducting telephone consultations, standard rules of history can still apply. But some specific questions to tease out of the patient whether or not they've got a cuff tear is comparing the current function to the previously what they would term normal function. When did this change and how it changed? Particularly, was there an identifiable moment of change that they can put the finger on? Now, this, as I've touched on, may at the moment be someone pulling on the starter switch or starter lever for the lawnmower. It may be after trying to lift a heavy pot in the garden. It may be that they've had a slip or a fall onto their arm. They've come off their bike. Or, as I say, a bit of DIY. They might have been making a table. They've lost position of the table. They've gone to grab it, and that sudden lever has caused a tearing phenomenon in the shoulder area. It's always good, therefore, to try and get as much detail about that mechanism of injury for the patient as well. That can really help too. They'll probably describe pain, and they'll probably describe weakness, but often it might need a bit of focused questioning, a bit more focused than what we'd perhaps ask face-to-face to tease out these specific things. And a common occurrence as well is difficulty sleeping for patients when they've torn the rotator cuff. Now, one of the advantages of video consultation, top tip here, we can still ask patients to kind of point to the area where in the shoulder where they feel the site of their pain. And that's a good clue to shoulder pathology. Now, we are in lockdown, so all of us are, maybe putting on a bit of weight. I'm no different. I like to think this is a picture of me in better times, and we'll use it as an example of different sites of pain. So, Giles, if you could throw up the poll, if we were to ask where in the shoulder people generally describe pain of a cuff tear, is it pink, is it yellow, or is it in the green area? What do we think?
Just realised that for some people the poll may actually sit over the picture, so that's something for us to bear in mind for the next one. So we have.
It's possible to move though. If you drag it, you can. I've just moved it myself, Giles. So that is.
Yeah.
Possible.
So if you individually just shift it to one side, you can actually do that. You may not be able to do that on all devices because some functionality isn't there.
Okay. Well, to describe then, pink is superiorly, yellow is anteriorly, and green is laterally over the deltoid. If that helps.
Brilliant. Okay, so we're up to about 70%. So I'll stop it there. So of those, you can see that 7% answered pink, 78% answered green, and 15% answered yellow.
Brilliant. So as per expected then, we're probably all quite familiar with patients describing pain laterally in the arm. And this, generally speaking, it's a good rough way of looking at it. If someone points to the top over the AC joint, the pink area is shown there. It's often ACJ pain. It's probably from the AC joint. Someone puts their arm down the side, rubs their deltoid this way, often down to the elbow itself, say it radiates down into the elbow. That's very commonly a cuff tear or impingement as well. And yellow, it's more central. It's more the osteoarthritis, the labral tear, and traditionally frozen shoulder, although as we know, frozen shoulder can present with pain anywhere within the shoulder. Some other things we can do with the video consultation, we can get an idea about the movement of a patient and compare their active and passive range of motion. And that's quite useful in determining whether this is a cuff tear or not, because as we know, if there's a cuff tear, a patient won't be able to actively elevate their arm, but passively or actively assisted, they may be able to get their arm up. Similarly, if they've got a different diagnosis, such as frozen shoulder, they just would have restriction of movement both actively and passively. So a couple of top tips, if we can demonstrate them to you. Giles, if we could switch to the full screen now, is that possible?
Yeah, absolutely fine.
Okay, so something like a golf club, if I step back, what we can do is say we're going to examine this arm here, so this is my right arm. If we take a golf club, if we ask a patient, can you externally rotate, and they can only say get to there themselves, we'd ask them to hold the golf club, keep their elbow tucked into the side, and do a bit of active assisted or passive range of movement there. That's quite a big clue for us to know that they've still maintained passive external rotation in the absence of lack of active or loss of active external rotation. Now, if they remain to be stuck there, we know that that's similar, and that's more in keeping with a frozen shoulder picture than a cuff tear. Similarly, if we angle in a certain direction, we could do abduction as well. We can elevate to the side. So we can really abduct all the way up with minimal effort with my right arm, but guided by the golf club and my left arm there, as opposed to potentially just elevating to there for the torn rotator cuff tear. So there's a couple of good tips there which we can use both for examination purposes, but also potentially for treatment purposes afterwards as well, particularly to try and keep patients keeping their range of motion with treatment.
Just one quick question that's come through from James Carter, just saying, would there be much bearing of a dislocated or very mobile sternoclavicular joint on the rotator cuff area, do you think?
Just say again, Giles, sorry.
It said, from James Carter, would there be much bearing of a dislocated or very mobile sternoclavicular joint on a rotator cuff tear? I think that was more in relation to the areas that it was marking. Okay,
so sternoclavicular joint, if it's symptomatic, would be more central around where the sternum and the clavicular tends to meet. So in my experience of pain at the sternoclavicular joint, they would feature, or pathology at the sternoclavicular joint, they would feature pain quite specifically at the sternoclavicular joint. That could either be through arthritis or subluxation of the sternoclavicular joint. I rarely see it with pain on the outer side. Now, the other way, if I'm understanding the question correctly, would that have an impact on cuff function? Yes, it would, because the the biomechanics of the shoulder are off kilter with a subluxed or displaced sternoclavicular joint. So there would be some abnormal pressure on the cuff. But generally speaking, in my experience, people who present with sternoclavicular problems present primarily with that rather than an issue with the cuff.
Okay, thank you.
All right.
Also, any suggestions of other things you could use if they don't have a golf club, for example?
Yeah, I was thinking about that. Maybe an umbrella, particularly in the UK with the weather today. That might be a suitable thing, one of those long umbrellas, anything like a stick, just something about mid-shoulder range, 50, 60 centimetres in length that is sturdy enough to help provide that support to the active assisted movement. So as I've touched on here, it's important because it shows restriction of movement due to weakness. And where that restriction is due to weakness, that's usually a problem connecting the muscle to the bone, i.e. the tear in the tendon. It's also useful in our history and an examination to try and work out whether it's a traumatic or a chronic tear, or perhaps even an acute on chronic tear. And the reason we do that is because that'll align our ideas about how urgent or how more likely a patient would be with surgery. Chronic tears, we know, do extremely well with a trial of physiotherapy over a long period of time. Traumatic tears tend to do better with surgery, and in particular acute on chronic tears tend to seemingly do better with surgery as well. Similarly, we know that when you do that surgery earlier, you get a better outcome. So the difficulty is going to be through lockdown, how best to manage that and how to continue providing the treatment for patients. And realistically, it is going to be simply to try and maintain range of movement until we unlock. Now, anecdotally, just as a side with that in mind, can we run a poll here, Giles, and see how people would think this type of fracture, this injury, would be best treated? And it's a displaced avulsion of the greater tuberosity in a right-hand dominant 50-year-old male.
So effectively, would you treat this non-operatively, operatively as an urgent or early intervention, or operatively as a non-urgent or late intervention? And again, just to mention, you may need to just shift the poll on your screen just to one side. You may not be able to do this on an iPad, for example, but just to make you aware. So I'll leave it up for another 10 seconds. That's good, we're at about 70% there, and share those results. So 23% are saying you would treat this non-operatively, 60% would be an operative treatment, urgent or early, and 16% would say it would again operatively, but non-urgent or a late intervention.
Okay, great. So how would people compare that to this injury? This is a 50-year-old right-hand dominant gentleman who fell over, hurt their arm, and there's no fracture on X-ray.
So again, how do we treat this? Non-operatively, operatively urgent early, or operatively non-urgent or late?
And it's not a trick question.
Okay, people have been very fast on this one. So we're nearly up to 80%. So I'll just end that one there and then share those results. So very much a shift here. So 83% saying non-operative conservative treatment would be their preference. Urgent operative treatment would be 9%, and non-urgent operative treatment in 8%.
Yeah, it's a bit of a no-brainer, really. That one's we've gone 76% in the first X-ray, people who'd operate, over 80% in the second X-ray who'd operate. But what if we were to say, within this X-ray, this is an artist's impression of a supraspinatus and a tendon, and the tendon is torn? What would we think about that? Would that change our mind? We're not going to poll on this one, but we're just going to have a think in our own minds as to whether or not that would change things. And this is a bit of a bugbear of mine, really, because we see a lot of people further down the line who've had such a situation. If a patient turns up after a fall, so the mechanism of injury can still be the same, they turn up to A&E, they have a greater tuberosity avulsion, they have a positive X-ray in A&E, so there's a fracture, so they get a referral to the orthopaedic team, and they're often seen in fracture clinic very quickly, i.e. within the first week. And then the majority of those patients, particularly if the fracture is displaced, go on to have an early or semi-urgent open reduction internal fixation. And that seemingly would be in agreement with what we polled there, 76% of patients. However, a cuff tear, people can still come to A&E, but because they've got this normal X-ray, they more often than not will be discharged back to their GP without any orthopaedic follow-up. Now, if they're lucky, they might get to see a physio, and if they're particularly lucky, they'll see a physio who's switched on, who'll see a patient and say, something's not quite right here. I think you may have had a cuff tear, even though you've had a normal X-ray. We've all seen the patients who come and see us and say, oh, I had an X-ray, I just got told it's soft tissue. And then they have to go in the process a different way through the elective process, and they take many months to the operation. So there are differences, but is it actually a different pathology? Is it a different injury? Or is it pretty much the same, where the supraspinatus is now no longer attached to the humeral head, with or without the infraspinatus being attached as well? Hence that principle that if you've got this traumatic acute tear of the rotator cuff, it needs reattaching as early as possible, followed by early rehab post-operatively to try and maintain range of movement and function in that patient's shoulder. So that's really the theory and the rationale behind why we think early surgery for traumatic tears seemingly works better. Now, conventionally, we'd go through an early diagnosis by obtaining a history, traditional examination like we talked about, and confirming with imaging. Now, depending on where we are in the country at the moment, I'd say pretty much everywhere, though, is similar in that we're having difficulty getting appropriate imaging for these patients, because essentially all imaging has been put on hold for just simply clinically urgent and emergency type of imaging needed. But in the ideal world, thinking back to where we're going to be when we come out of lockdown, if you've got a patient who has a rotator cuff tear, or you suspect a rotator cuff tear, what would you prefer as being the investigation of choice? And I think we've got another poll for that, haven't we, Giles?
Yeah, so what would be your preference for imaging for a cuff tear? Would it be X-ray, ultrasound, MRI, or none?
None being that you'd be happy enough with your clinical judgment.
So someone's asked, can we consider an older patient 75 years plus? Would you say?
Yeah, absolutely. I think age is an interesting phenomenon in general, isn't it? Because you can have a 55, 60-year-old patient who has a huge amount of comorbidities, and a 75-year-old who's got no comorbidities, who's fitter than I am, you know, and I've only just turned 40. So I see many people, and interestingly, we had, I'll anecdotally give a quick story about how when I first started in orthopaedic surgery, I was an SHO senior house officer, so junior doctor in Plymouth in England, and I was working with a top guy called Andy Murphy, top man, and if anyone who's listening knows him, they'll know what a great guy he is. And we were doing a cuff repair in a patient who was 62, 63. And he told me, we're pushing the limits here. We don't really do these in people over 60, 65. Now, that was back in the early mid-2000s, and we're only, 15 years on from that, and now we're pushing the envelope even more. What we do know is that somebody, generally speaking, the older they are, the less likely they'll have a positive outcome from a cuff repair. But even if they say have a 60% good outcome from a cuff repair, that's still 60% of people who are 75 who would do well following a cuff repair. And it's much easier to do that early than to wait and leave it a trial of 4 or 6 months for them, generally because of the retraction and the scarring and the muscle atrophy that they tend to get after that as well. So yeah, for me, age isn't necessarily a cut-off. It's more the physiology of the individual and their functional activity level.
Okay. So in terms of the poll, for what was your preference regarding imaging for a cuff tear, 1% said X-ray, 47% said ultrasound, and 51% said MRI, and 1% being none.
Brilliant, thank you. So yeah, interesting split there, almost 50-50. It's probably because there's pros and cons to each of these, isn't there? We've got more availability of ultrasound generally. It's a lot easier to refer somebody and to get an ultrasound for our patient than an MRI, which tends to have a more longer wait. Ultrasound's a bit cheaper, so in terms of traditional health economics, or even in the private sector with someone paying themselves, they'd rather not pay as much, so ultrasound being cheaper than the more expensive MRI. One particular advantage of ultrasound is the dynamic nature of it, where you can sit there with a patient, ask them to move their shoulder around and make sure you get that view of the tendon yourself, whereas the MRI is static and doesn't tolerate well people moving around, although the modern MRI machines are, well, fantastic really. 3 Tesla scanners, much like we've got at MIP, is fantastic. The downside though is that the ultrasound is very user dependent and therefore is report dependent. And as a clinician, you're very much guided by what that report says. And it's often a lot like trying to interpret what a photograph or a picture says and trying to describe that to somebody else. I might use terminology that makes sense to me, which doesn't necessarily make sense to the person that's receiving that report. The MRI scan, on the other hand, gives you more detail. It can tell you the size, the thickness, the retraction distance of any tear. It can qualify the amount of muscle atrophy seen in that tendon. It's therefore a bit less open to interpretation, I think, because as for most of us who then have looked at ultrasound scans performed by someone else and looked at static images following on from that, it's quite hard to interpret, I have to say. So MRI scans, as a surgeon, it does help me plan surgery, I think, a bit better and help predict a patient's outcome accordingly and plan the appropriate operation for them. So as a surgeon, my preference is MRI, but there's certainly nothing wrong with an ultrasound in terms of trying to get a diagnosis. Which leads on to the repair and how we go about repairing. This is a video supplied by one of the companies who make the repair equipment. There are other companies available, however. And this is effectively what we do. The supraspinatus is torn here. It's retracted. And we want to, first of all, freshen up the bed to fresh bleeding bone so that the tendon will heal back to the bone, which is the ultimate aim of this. We know tendon doesn't heal very well to bone, so we need to encourage some biology that way. We can then take an awl and create a hole in the medial aspect of the humeral head, medial to the greater tuberosity, and in that hole we place an anchor. These more modern anchors are made of, really speaking, better biomaterials now than the traditional first generation of anchors. And they're also loaded now more with tape rather than suture. The idea being that suture used to cheese wire through the tendon, whereas the tape, with it being broader and more surface area, is less likely to do that. So we can use these arthroscopic passing tools and instruments to pass the tape through the tendon. And then we can repeat. And the popular technique now is the so-called double row. So we place 2 anchors loaded medially with tape in each of them, separate the tape, and then take a strand of each to place through another anchor, which we'll place into what we call the lateral row. And again, if you watch the gap in the tendon there, it's closed off as we tension down on the tape, make another hole, and we lock it in place with the appropriate tension using another anchor. And what this does is, the presence of the tape is that because it's broader, it spreads across a wider surface area. It causes more of a compression of that tendon into the bleeding area, hopefully therefore encouraging more healing, but at worst giving it a much more stable construct than what we saw previously. Then we can repeat that as part of the double row technique. We put 2 anchors medially, 2 anchors laterally, so-called medial and lateral rows. And this crossover effect that the tape causes here, again, creates a very nice compressive episode to give increased contact forces and hopefully help healing. Now, because of that, these more modern techniques, tape instead of suture, stronger anchors than we saw before, the double row technique rather than a simple single anchor, the suggestion is that we can rehabilitate these patients quicker. Now, there's still some debate as to whether or not that actually helps people longer term, but there are other ideas that suggest that, well, people don't like a sling. Can we mobilize them without a sling for the first few weeks? And the evidence is suggestive that, at least for smaller tears, less than 3 centimeters in size, we can. There doesn't seem to be a detriment to the outcome from doing that. There is potentially even a benefit, depending upon which papers you would read and advocate. It should also be noted, though, that there are other factors to consider rather than just the size of the tear. Some people would still want, for a large tear, i.e. over 3 centimeters in size, a more prolonged period of immobilization and rest to try and protect the repair, because inevitably there will be more tension on the repair from a bigger tear. Similarly, in a patient who has other factors associated with an increased re-rupture rate, i.e. smoking or diabetes, we may in those individuals want to protect the tear again. But it's certainly on the horizon and something to keep an eye on going forward about how we can progress through rehab a bit more quickly when we do eventually get to repair these tendons once again. Speaking of which, if we go back to the situation in lockdown, what are some of the challenges we will face? Because we've just gone through what would be a more traditional type of management: history examination, diagnosis, imaging, surgery, and the acute tear. Well, we can't offer surgery at the moment, and we can't offer it until goodness knows when. We don't actually know at the moment when we'll be able to start operating on these people. And so this is where actually, you know, physios who are still conducting telephone and video consultations will play a huge part going forward. We can use this time really to try and prevent stiffness and this idea of a post-traumatic frozen shoulder. So if it's on our radar that this phenomenon could happen, there could be a surge in cuff tear, we can start patients on active assisted passive range of motion, obviously a lot more refined than I showed you with my golf club. But even just little things like that will help try and prevent this frozen shoulder, because it's very controversial still to do a repair in the presence of stiffness. It may necessitate a manipulation under anaesthesia or even a form of capsular release before actually doing a cuff repair. And particularly if we're then going to immobilize them afterwards for a period of time, that could be a problem with stiffness going forward longer term as well. So a big way of getting ahead of that curve will hopefully be mobilizing now when people contact you with their shoulder ailment. So that's something worth considering in terms of what we can do. Now, going forward, a proportion of those patients will then ultimately end up compensating and hopefully not even need surgery when all's said and done.
On that topic, Jack Baines just said that currently have a patient with suspected supraspinatus rupture. We've achieved fairly good range of motion using surrounding muscles. Besides long-term range of motion issues, are there any other negative implications of having to wait months for surgery whilst we wait for lockdown to pass, such as a failed surgical repair, for example?
Yeah, what we know is that the longer we leave things, or the longer we leave a traumatic tear, the harder it is to repair, because there's a risk of retraction of the tendon, there's a risk of scarring in retraction, and there's also a risk of muscle atrophy or fatty change of the muscle, which means even if we do repair it and we get a successful repair, the muscle may not actually function afterwards. So that's the theory and the logic behind not leaving a tendon long term. The flip side is there are a proportion of people who, as I think Jack's seen perhaps with this chap, that can compensate, and it's very difficult to try and have that consultation with someone who is pain-free and has good function and range of movement by saying you should have an operation, because as good as we are at cuff tear in the modern day, there's still risk associated. So this is where the bespoke treatment comes, where you have to kind of make your decisions and you know, joint decision making with the patient that way on a bespoke level with the patient. Now, if this is a youngish gentleman or female in their 50s, they're going to have to live a long period of their life with a deficient cuff, which does predispose them to a phenomenon called cuff tear arthropathy, where the biomechanics of the shoulder are altered and it leads on to a quicker degenerative change within the shoulder. So there is potentially a problem there If it's someone who's older, their life expectancy is probably a bit less, and so their function, if it's okay for them at the present time, might be that they've been able to compensate and they can escape the need for surgery.
Okay, great.
Is that right? So
yeah,
it leads us on nicely in a way, really. Post-lockdown, when we unlock and we start seeing patients again, some of these patients who do have a cuff tear through the lockdown period will end up compensating and they won't need an operation. But for those with pain and no active range of motion, they probably still benefit from the surgery. And again, as we've touched on, the sooner the better. And I guess following on a little bit from Jack's question as well, if we leave it too long, what do we do if a repair is not possible? And this can happen because the tendon is retracted, there's big muscle atrophy, and it's generally speaking very scarred down and technically difficult to do, sometimes possible to partially repair, but then functionally it actually makes little difference to the patient. And these are our options for irreparable cuff tear. And as you can see, there's plenty of options, and to go through these independently for each of them would be a whole another talk in itself. So this is me now pitching myself to Össur to see if there's appetite. I can come back in a few weeks and maybe do another one talking more specifically about the evidence for each of these as an option. But one thing which has become very popular in recent times, in the last couple of years, is this. It's called a superior capsular reconstruction. And personally, it's my procedure of choice for when there's an irreparable cuff tear. And what we're trying to do is use this dermal allograft and basically reconstruct the superior capsule to prevent that proximal migration of the humeral head. Thought being that when the humerus migrates proximally, it rubs against the undersurface of the acromion and causes pain, and that then limits range of movement and function. So how we do this, we effectively try and make a bed on the glenoid and a bleeding bed on the humeral head, which will be able to promote healing, to take this graft, that, as I say, it's a dermal allograft, so it's from a donated dead person's dermis or skin, and it's often the skin on their back because it's of a suitable thickness. We then place 2 anchors medially in the glenoid and 2 anchors laterally in the medial aspect of the humeral head, much like we'd do for the rotator cuff repair that we saw. Then we can use this arthroscopic ruler to determine the size of the graft that we need. Often the graft is given much bigger than what we need, and so we can draw on it these appropriate sizes, measure it, and cut it back to size, because again, ultimately we want something that principally keeps the ball on the center of the socket, which should then allow us to activate deltoid, activate our other cuff muscles, and tip this patient over into a compensated movement, as well as causing a barrier between the humeral head hitting the undersurface of the acromion. We then take the graft and we pass a load of the sutures through it. And this is quite a technically difficult part of the procedure because a lot of the sutures can tangle up. So although this animation makes it look very simple, it's quite a tricky thing to do. So there's a lot of planning and suture organization and care and attention to detail. But in essence, we take one of the blue ones, one of the white ones medially, tie them together, and then use this arthroscopic instrument to help pass the graft into the shoulder, which again can be quite a fiddly phenomenon. We then lay it down by shuttling and tensioning the sutures appropriately, and then either suturing or tying the 2 sutures together immediately, and then laterally, as we can see, effectively recreating what we did for a cuff repair. Then medially, there's other things you can do. You can either place an additional anchor with those sutures or place a couple of anchors to tie down the 2 corners of it as well. And then finally, what we like to do is try and reattach the back of this graft, or the posterior aspect of the graft, to the superior or upper border of the infraspinatus to seal off any potential for superior escape. You will notice, though, that anteriorly we still maintain the rotator interval and leave that open, because tying that off tends to tighten people up a great deal. Now, in my experience of doing this, we've had a particularly good outcome in terms of patients who describe good pain afterwards. So it almost unanimously has helped with pain for patients. Function's a bit more variable. Generally speaking, in the chronic cases where we've done this, what function you've got going in is what you've got coming out of it. Although there have been a few cases that I've seen who really commit to their rehab really fire up deltoid, and they've done quite well. So that would be my answer, I suppose, to what do we do if we've left it so long that we can't do a cuff repair. The other thing just to touch on briefly that came to mind is, once we unlock, we're probably all going to go crazy and start doing activities which we haven't done for a long time, because we're all desperate to go to the gym again or go and play golf again, especially if the weather's nice. Gym owner friend of mine he's quite excited, but also a bit fearful, in the sense that he thinks it's going to be like the worst new year ever, where tons and tons of people are going to try and rejoin the gym when lockdown is over. So we talk about the second wave of COVID. We may get this second wave of cuff tears due to COVID-19 and the lockdown. If it does last for 3 months, we've had 3 months of inactivity, and a sudden return, as we all know, returning too quickly, loading what is inevitably already a degenerative tendon, makes that tendon liable and likely to be torn. So patients may suffer a new acute cuff tear as a result of the lockdown period when they restart activating afterwards. And that, again, will be difficult, because there'll be a delay to presentation and treatment because of the pressures on the healthcare system. We've still got patients that were put on waiting lists back in December, January, February, before we shut down elective work, who'll still need their procedures doing as a priority. We've then got the cohort of patients who, through lockdown, will be tearing their cuffs, who will present en masse, and then these individuals afterwards. Hence why I think we're going to have to catch up on these delays caused by COVID, and why I think the lockdown cuff tear will become a certain phenomenon. So just to summarise and bring everything together, I think cuff tears are likely to be a common occurrence in this pandemic and during lockdown, and even after lockdown, we're going to have a large influx of patients with cuff tears. We can do what we can do. We can only do so much at the moment, but that would be helping with mobilising the shoulder as much as we can. And surgery will be an option for a lot of these patients when we're able to do it again. So all that's left for me to do is to have a very shameless plug for the BOSTA conference, the British Orthopaedic Sports Trauma and Arthroscopy Association. It is a surgical society predominantly, but we do pride ourselves on being approachable to the whole MDT. So, for instance, membership, if people wanted to join, is a bargain at £25 a year, probably the best value for money membership of any society in the UK. And it's open to surgeons, MSK doctors, sports med doctors, also physiotherapists, and anyone really working in sport. And if you become a member, you instantly get your money back if you come to our conference, because you get £25 off the registration fee for the conference. At the moment, we still plan on going ahead at the end of November, but obviously that could all change going forward as well. So if you want to learn more about that, check out bosta.ac.uk. And if anyone in particular wanted to join, please feel free to email me or reach out to me, and I can facilitate that for you. So thanks again to Össur. Thanks to everyone for listening. Please do stay safe. And, you know, I think we've still got a few minutes, haven't we? So happily answer any questions that you could put to Giles to put to me. Thanks again.
Brilliant. Thank you very much, Neil. So what I wanted to do is we have a variety of questions that have come through. So I'm just going to go through some of those as we go. So a couple of questions about anterior deltoid programs. What circumstances would you use them, and what are your thoughts on these types of programs?
Yeah, really, that's something I don't have as much familiarity with as physios would, really. But my idea for effectively the deltoid has always been about trying to achieve balance. So anterior, mid-portion, posterior deltoid, I think, are all important features of the deltoid. Now, a proportion of patients I see, particularly boxers, because they focus on their anterior chain so much, including anterior deltoid pec, they tend to end up in this protracted impingement positive type posture. And for a huge proportion of them, we end up having to do a lot of band work, scapular retraction, posterior deltoid, rhomboid scapular stabilization stuff for them. So I guess the thoughts on it would be everything in moderation. I don't think there's a problem with it, as long as we balance it out accordingly.
Okay, fantastic. There's a question very early on from Liam Swain saying that you mentioned traumatic tears do better with surgery sooner. What do you think about degenerative cuffs that have had a traumatic event that potentially progressed to a full thickness, then result in ongoing pain? Would you manage those as an urgent surgical case?
Yeah, it's a really good question. Really good question. I think, you know, one of the focuses of the orthopaedic literature, an unanswered question as such, is exactly that. The trend would be that we're tending to call these acute on chronic tears. So trauma in someone we think has already got a tear as well. They do seemingly still do better with earlier surgery. So the difficulty is knowing how much of a tear have they had previously. That being said, I guess now in the modern day, we've got easier access to ultrasounds, MRIs, so we've got more of an idea if someone's got a tear, and if we can keep them going for a period of time with a partial thickness tear, happy days. You know, if they can avoid surgery, great. But if that then becomes a full thickness tear, particularly after a trauma, the suggestion is that they still do better with surgery sooner.
Okay. And a question from Enda Gavin. Are there any considerations with regards to steroid injections for cuff tears?
Yeah, again, so what we know is that traditionally we've given steroid injections periodically. I've done it myself in particularly elderly patients whom realistically aren't a good candidate for surgery, or they just choose not to expose themselves to the risks of surgery, which is absolutely fine. It again links into the shared decision making and that bespoke treatment that we were talking about. What we know as a general population is that one steroid injection in the presence of a cuff tear doesn't seemingly change the outcome following surgery. But what we know is that when they've had a second injection and then go on to subsequent surgery, they don't tend to, as a group, do as well as people who've had one or no injections. Similarly, the more injections you have, the worse your outcome tends to be. Now, that's slightly biased because you're obviously having a delay in surgery with injections, so there's a time feature as well. But in my practice now, generally speaking, if someone has one injection, if we meet, we have a discussion, they want to explore non-operative options first, I've got no problem with that. It's their shoulder at the end of the day. It's about informed decision-making for that patient. So we can plan an ultrasound-guided injection, because that's the other thing. I think it's important that we know we're getting it in the right place. So we do an ultrasound-guided injection, structured physiotherapy program to which they have to be compliant, and then a review 12 weeks later. And they generally go one of two ways. Either they're not happy, and if they're not happy, then we'd guide more towards surgery, or they've compensated. And if they've compensated, great, keep an eye on them. And then at some point, that injection tends to wear off, at which point we then have the discussion, well, you could have another injection, but what it means is that if we do go on to do surgery, it'll be less likely to be beneficial. But then again, there is risk of surgery. So, you know, again, it all comes down to the individual, I suppose.
Okay, fantastic. We still have a few remaining questions, which I think we'll perhaps come back to afterwards. So as long as Mr. Jain's okay with that, we'll perhaps send out a few emails as we did last time. That's perfect. It just remains to say thank you to Mr. Jain. A very interesting and very different talk to some of the ones we've had before, and I certainly found it very, very informative. I really wanted to just point out that we have recordings of all the previous webinars that have gone on before on our YouTube channel, so you can go to those if you need to. Quickly, just pass over to Neil to say thank you. So if we'll just highlight you there, so you can say thanks.
Yeah, no, thanks everyone for logging in. Thanks for spending your afternoon with us. Hopefully you found it useful. And once again, big thanks to Össur for putting this on, particularly for something which really I haven't even promoted any of your stuff. So, you know, that shows how much you like education. So big thanks to Giles, Stuart, all the team at Össur. Shout out to Peter Gill, I know as well, he's big keen on his webinars. So thanks to all of you, much appreciated.
Thank you very much. So the last thing really is to say about our next webinar. So this is next week, and please note that this is on a Thursday due to the fact that Mr. Christian Ingle, who is going to be presenting from Sophia Hemmet Hospital in Stockholm. He's actually operating on the Wednesday. Things are a little different in Sweden. So we thought it'd be really good to involve some of our colleagues from the Nordic region. Mr. Christian Ingle will be presenting about painful, non-traumatic disorders of the hip. So we're really excited to have him in for that session. So thank you very much. We hope to see you next week, but please remember that it's on a Thursday. Thanks, guys.